So I think I'll slowly get started just to be mindful of time, and maybe if I just drone on a little bit about who I am, the people can walk in and give us a couple more seconds. So I'm Dan Moran. I'm a nurse practitioner at Dartmouth in primary care, so I do practice what I preach. I've been practicing since 2000, and interesting enough, all my patients are now 25 years older than where they were, so I didn't know much about geriatrics 25 years ago, but not only am I one now, I am now having to take care of older patients. I am only 20% clinical currently. I sit on multiple different grants. One of the grants that I sit on is with the Dartmouth Centers for Health and Aging. It's called a Geriatric Workforce Enhancement Program grant. We're going to hear a little bit about that a little bit later. Basically, we work with primary care practices on how to provide better care to older adults, and we do that through 4 Medicare reimbursable codes. So the annual wellness visit, chronic care management, transitional care management, and advanced care planning. Another grant that I sit on is out of Mass General and Harvard. They have this huge PCORI grant where they're comparing the annual wellness visit to the annual wellness visit plus a model that they created called the GRACE model. So I am in charge of standardizing the annual wellness visit across 32 different practices that they're doing. So that's a pretty big grant. That's like, I hate to quote money, but it's like a $25 million grant. It's a very large grant. Then also I work for Population Health. I helped create all the adult screeners for Dartmouth. So if you get your care at anything with the Dartmouth logo on it and you did one of those screeners, I probably created that. Originally, when we started off with that, we thought that was going to be a nice quick little project. Basically, it took us 3 years to create the screener, and that's a very long time, but every question we asked had to be validated, and every question we asked, we had to have a workplace in plan to deal with the positive findings. So it wasn't that easy, and then you throw in the social determinants of health, or social drivers of health, or drivers of health, or whatever we're calling it these days, that even makes it more challenging. So not only do I practice what I preach, but I'm also involved a lot in implementing some of this stuff. And everybody can hear me still okay? Okay. So I have no financial disclosures other than, again, I am partially paid by this Geriatric Workforce Enhancement Program grant, which is a HRSA grant. And as of currently, we are still protected for at least June of next year. So after that, we don't know. Right now, we're living year by year, but the grant was originally covered till 2029, so we will see what happens with that. So today's agenda, we're going to start off with very exciting vehicle inspection information, just to make sure you're all up on your vehicle inspections. We're going to talk a little bit about the annual wellness visit, a little bit of the overview and the dementia gap associated with that. We'll talk about a nurse-run Medicare annual wellness visit, and I'll give you a little bit of information about this geriatric interprofessional team transformation of primary care. I don't know why we came up with that name. We shortened it to Get PC, so anyways, and then we'll do a call to action and Q&A. I actually planned on this ending a little bit early, which usually I run exactly to the last minute, and then there's so many questions I feel bad. So I've tried to do a good job really shortening up my presentation, but I also do have some slides after the thank you slide to talk really about some of the billing in FQHCs and non-FQHCs around the annual wellness visit. So if there's interest in that and we have time, I'll include those, and if we don't, I won't include them. All right, so let's talk about our vehicle inspection. So every single year, so by the way, I'm from New Hampshire, guess what? January 1st, we no longer have a vehicle inspection, so that means everybody's brakes are going to be bad and we're going to be crashing into each other. Well, that's a different story. So in Vermont, you still have a vehicle inspection. And of course, there's this huge list of stuff that the person, the mechanic, has to go through to make sure that you pass. And you have to go to a certified inspection company, and I think most of them are that way. And then, you know, so here's the guy with his clipboard, and he has his white gloves on, because this is what my mechanic looks like. You know, so he's looking at everything on there. I'm surprised with the white gloves, gotta love them. But you notice he does not have a stethoscope involved in this care at all. But the good news is they give you free brakes at the end, right? So when your car needs brakes, they're like, hey, we'll throw those in for free, right? Yeah, I'm only kidding. So by the way, this is the Medicare annual wellness visit, right? So we have all these different things we have to check off. The visit officially does not require a stethoscope unless you're doing a blood pressure, but there is no physical exam. And if you need a brake job, we can't give you the brake job as part of the annual wellness visit. We have to charge you extra for that. And we may have to bring you back at another time to talk about it, right? Same thing with your mechanic. You know, sometimes they're like, yeah, we can deal with the brakes now. Sometimes they're like, nope, we have to bring you back. So this is the annual wellness visit in a nutshell.
Right.
So just some terms I want to go over because, you know, one of my least favorite parts about my job is trying to decipher what the heck Medicare is actually talking about and just learning some of the basic acronyms and phrases. And I will do my best not to use acronyms to the best of my abilities unless I've said them like 10 times and told you what they are 10 times. So we start off with sort of this generic phrase called Medicare wellness visits, okay? That's a huge umbrella term, and underneath that, they have sort of two primary focuses. They have the Welcome to Medicare visit, which is also called the Initial Preventive Physical Exam. I dislike that title because right in there it says physical exam, and they cannot get a physical exam during that visit, so I'm not a fan of that. And then outside of that, we have the Medicare annual wellness visit, which are visits that happen every year after that. So with the Welcome to Medicare visit, this is a visit that can only happen within the first 365 days of being enrolled in Medicare Part B. So if you show up on day 366, I cannot do that visit. I have to immediately go into an annual wellness visit. Then of course the annual wellness visit has two visits. It has the initial annual wellness visit, which is just the very first time you do it. There is no time frame. So if you are a person who doesn't get an annual wellness visit for 5 years under Medicare Part B, you're still getting that initial annual wellness visit. And then after that, it's a subsequent annual wellness visit. And really the biggest difference between these two is the initial annual wellness visit is where you're sort of creating these components, and then every year after that, you're updating it. And one major difference between the Welcome to Medicare visit and annual wellness visits is the Welcome to Medicare visit can only be billed by a provider, by a physician or a nurse practitioner or PA or certified midwife, and the list goes on and on. But the annual wellness visit in non-FQHCs can be done 100% by a nurse and billed incident to. We're going to talk about that a little bit later. So, and for all of these visits, one of the key components is this thing called the health risk assessment. This is the questionnaire that has to happen, and that questionnaire supports those visits, okay? So that's sort of high level, Welcome to Medicare visit, and the two annual wellness visits and the time frame. Now, one of the confusion about these is they can only happen 365 days away from each other, okay? So if for some reason you don't want the Welcome to Medicare visit, you cannot get an annual wellness visit until at least day 366 of being on Medicare Part B. You can't get an annual wellness visit the first year. The first year would be that Welcome to Medicare visit. So if you did get a Welcome to Medicare visit, you have to wait at least 365 days before you get an annual wellness visit and so on. Unlike some insurance companies that allow it to be calendar years. Now, when I talk about some of these rules, I am specifically talking about original Medicare, Medicare A and B, in this case Part B. Medicare Advantage plans, some Advantage plans say calendar years. They don't necessarily have to be exactly. Not what I'm talking about today, because I can't keep up with all those rules. So we're just talking about good old-fashioned Medicare Part B. So what is the Medicare annual wellness visit and what it is not? So sort of what we've already grouped here a little bit is, first of all, it's a free visit to the patient. Medicare Part B, excluding if you have gap insurance and all that, under Medicare Part B, the patient pays 20%, Medicare pays 80% of most of your visits. So if you go in for knee pain, Medicare's paying 80% of that, and you as the patient pays 20%. Medicare says for these annual wellness visits, you pay nothing, none at all. It's 100% covered, so it's a free visit. This is a focused visit really on early detection, prevention, and healthcare planning. It is not about evaluation management of current ongoing issues. A lot of screening and coordination goes on in here. We're going to talk about that a little bit further. And really talk about the patient's engagement in their long-term care, okay? What's not included? A physical exam. By the way, if you're somebody with Medicare Part B and you tell your doctor, I only want a physical, give me that good old-fashioned head-to-toe physical, Medicare covers 0% of that, not even the 80-20 rule. They cover nothing. You as the patient would owe 100% of that visit. So, if you're a provider and somebody's telling you they want a physical, they better really, first of all, either have Medicare Advantage, and they should really know that it's covered, but they should understand that Medicare does not cover any of that. So that could be a huge issue. Also during the annual wellness visit, acute and chronic issues are not covered. We're going to get into some of the specifics about that a little bit later. Head-to-toe physical exam is not covered, hence the no stethoscope needed for this visit. And, you know, one of the interesting things about that is patients, if they're not well educated on the annual wellness visit, they show up and you don't pull out your stethoscope and you don't do a physical exam, they complain. Back in 2016, we were working with a practice in Vermont, and the doc did not pull out his stethoscope and did a visit, and the patient got really mad, and the patient went to probably somebody in this building and complained, and that person went back to the doctor and said, I just got this patient complaining that you did a physical and never whipped out your stethoscope, and started like really laying it into the doctor, and the doctor's like, it's an annual wellness visit. There is no stethoscope involved in that visit, right? So there is huge patient education that's needed about these visits. By the way, I have sort of all the Medicare books going back to 2015. The original Medicare book in 2015 had one paragraph in this book about the annual wellness visit. Now it has a couple of pages, but now that book is a lot thicker. Guess what? No, 80-year-olds aren't looking at this book, right? So no patient education, really. This is really challenging. So anyways, any questions about sort of what it is and what it is not?
I understand the physical exam is not covered, but is there at least a contracted rate where, like in Vermont, if a person wants that physical exam, a Medicare beneficiary wants it, they're paying the same as someone in any other state?
No, so if they want a head-to-toe physical exam,
Yeah.
so that's going to be billed out. So one of my challenges is currently I'm working in FQHC, so I always have to make sure which one I'm speaking about FQHCs versus non-FQHCs. So I work in a non-FQHC. If you're an older adult and you come to me with Medicare Part B and you want a physical, I know a physical bills out about $140. But I'm also working at Dartmouth, which means there's a professional fee and a facility fee. I don't know if you know the difference between the two. The professional fee is supposedly my charge. If I worked at the little mom and pop shop, that's what you would pay me. You would pay me $140 for that physical. But because I work at Dartmouth and we have an MRI machine and beautiful lights and a secretary and nice gardens, we get to charge you a facility fee as well, which is about the same as the professional fee. So that physical, if you had Medicare Part B, would now cost you $280 for that physical. And Medicare is going to cover 0% of that, so you're going to owe that all out the top of your head. So there is no standard fee. And of course, you know, insurance companies, as we know right now with all the Medicare Advantage stuff going on, all these insurance companies negotiate pricing with all these different facilities. So there is no standard fee. But at Dartmouth, it'd be about $240 because you'd get the professional fee and then you would get the facility fee on top of that. Fair or unfair, that's not up to me to determine. And I don't get any of that, right? They just pay me into my hourly wage, so, whoops, sorry about that. So we talked a little bit about, today's focus is really gonna be around the annual wellness visit, not that welcome to Medicare visit, so let's focus on that. So first of all, we talked about sort of the initial and subsequent, where the initial is really about initiating the components or establishing them, and then the subsequent visits are all about updating that information, and we're gonna get into that in a half a second. So the patient has to be enrolled in Medicare Part B and have to be at least 365 days from a previous annual wellness visit of some kind. There are sort of two main components of the annual wellness visit, that being the health risk assessment, that questionnaire, and then the actual visit itself. And again, we're going to get into some of those components. So let's talk about the health risk assessment first. So the health risk assessment is this big questionnaire. And as I mentioned, one of my other jobs that I do for Dartmouth, I helped create this for Dartmouth. We called it the adult screener instead of the health risk assessment. Our adult screener has a bunch of built-in logic to it. So if you're a female between 18 and 46, you get intimate partner violence. If you're someone over 65, you get elder abuse questions. If you have Medicare, regardless of your age, you get the questions for the health risk assessment. So all sorts of built-in logic. But basically, this is self-reported information. And if you look at the second bullet point, it wasn't that I was doing this really late at night, but Medicare says you or the patient should complete the health risk assessment during or before the annual wellness visit. So in my grant that I work on, I'm the bad cop, unfortunately. So I always yell at clinics and say, why am I paying the doctor 20 minutes to sit in the room with the patient and go through this questionnaire? It's a lot of money. Medicare says the patient should be completing this before the visit as well. So we try to really push this. We try to really work with the patient portals. And if you don't have a patient portal, having an iPad or a tablet, sorry, I shouldn't use a trade name here. So having a tablet in the waiting room to complete this. Now, before anybody raises their hand and says, my patient's 80, they don't know how to use an iPad, I call BS on that. My dad's 91, he's still working on an Apple computer. There are 40-year-olds, my other brother, who has no technical ability of any kind, and there are older adults that can run circles around me. So I don't think we should just say, because the person's older, they don't have the abilities to use these technologies. Because we've been in practices where they have not been used in the patient portal, and we got them working on that patient portal with the older adults to complete this health risk assessment, and they have done really well on that. And also this health risk assessment should not take more than 20 minutes. Our adult screener is really bad, even though I helped create it, I'm gonna say it's really bad. It's very lengthy because first of all, we start off with the behavior health bundle. So we ask the PHQ 2 to 9 and the GAD 2 to 7, and then we ask about alcohol, and then we ask about substance use. Those questions right there and the logic behind them, you could maybe only answer 5 or 6 questions, but you potentially could answer 40 questions if you were really somebody who had positive all of these things. So these questionnaires are really challenging because if you're an older adult that has a lot of positive things, that questionnaire is probably going to take more than 20 minutes, okay? So, and in our questionnaire, you can see this is our true questionnaire that we screen older adults for cognition. First of all, we give them a little story about what's going on, and then we say, during the past 12 months, have you experienced confusion or memory loss that is happening more often or is getting worse? And it's a yes, no, don't know, or decline to answer. And depending on the answer of that question, we will do a mini cog or a MOCA in the exam. We're going to get to that in a half a second here. So this health risk assessment that Medicare says we have to do, again, going back to Medicare loves making things as clear as mud. They say, here are the topics we should be asking: demographics, health status self-assessment, psychosocial risk, behavior risks, ADLs and IADLs. So ADLs being activities of daily living, IADLs being instrumental activities of daily living. And social determinants of health, their phrase, now I think people prefer social drivers of health, or again, who knows, it's called 80 different things at this point. But you notice there's a little number 2 after social SDOH. I'm just gonna use the acronym because I'm gonna confuse myself by trying to figure out which one I'm gonna call it. So social determinants of health currently has a little number 2 after, which means Medicare says this is an optional element of the annual wellness visit at this moment. And that just went into play in 2025. Now, in November of 2024, when we knew this was coming and we were redoing our training program, we said, aha, we think SDOH is going to be a required element probably in 2026. Medicare is just getting us ramped up. Then we have the change in administration. We have no idea what's going to happen next year with this. I don't think anybody does. But I won't be surprised if SDOH in the very near future becomes a required element of the annual wellness visit. Right now it is not. Also for demographic and health status self-assessment, you'll see a little asterisk, a little 1. So for demographic data, Medicare says you just have to ask demographic data. It doesn't give you very specific information. Same thing for health status self-assessment. This has got to be like one of the biggest components of the annual wellness visit, and Medicare doesn't even go out on a limb and tell you what you have to look at, right? So instead they give us an asterisk of a number 1, and they say, go look at the CDC's health status assessment and use their guidance. They're not even 100% clear, but they say, well, you probably should ask health status, memory, and physical functioning. What the heck does health status include, right? They left it so vague, right? So you could ask one question about health status, or if you had some validated screener at some point, it could be 10 or 15 questions, right? So left it really vague. And of course, the reason we're all here today is memory. So memory is encouraged to address during this health risk assessment. And as you saw before, that was our question for that. So anyways, these are all the different components that the health risk assessment needs to include. Then the patient shows up for the actual appointment, and there's more stuff we have to do. So first of all, we're sort of establishing family history, past medical history, and all that kind of stuff. Like I said, I've been practicing for 25 years, not anymore, but even just a few years ago, when I would do an annual wellness visit on a patient of mine, I opened up the family history and it was blank. I scolded myself. How could I have been managing this patient for 20 years and never did a family history on them? Why not? Because in healthcare, when the patient shows up, what your plan is gets thrown out the window, right? It's their agenda. They're bringing 8 acute issues during your physical exam, so you never get a chance to do any of that. So this is another good thing about the annual wellness visit is it's dedicated time to really polish some of this stuff up. Now, interesting enough, I am not a geriatrician, but we have a geriatric department, and I ask them, like, what family history, who should I go after? They're like, mom, dad, kids, siblings, that's it. And now they're even saying, like, maybe you shouldn't really even focus. If the patient's 88, does it really matter what happened to mom and dad? The patient's 88, like, they probably beat whatever the odds were back then. But anyways, so you can see this whole list of things. Now, good news for us, some of the components, Medicare says we either have to directly observe this or ask a screening question about it, and you can see sort of the list of topics. By the way, I'm paying the patient to do this, so I'm doing this as a questionnaire. I'm not paying the provider to do some of this stuff. Now, that being said, if the patient identifies a falls risk on the questionnaire, we are doing a 5 times sit to stand. We used to do the timed up and go test, but what we realized is my clinical exam room is about the same size as a cell in a prison, so I don't have 10 feet to do a timed up and go, so I would have to bring the patient out into the hallway. Well, there goes confidentiality. And not only that, every once in a while I'd get one of these older guys who thinks he's trying to break the world record in the timed up and go and be like diving for the chair and stuff like that. I was like, no. So we have switched to the 5 times sit to stand, which is just a timing. You can do it right in the exam room. And not only that, you can do that virtually now too, which is great. So anyways, and you can see the same thing, screen for potential substance use disorder. So when we went back to our questionnaire, again, we asked those questions. But again, screening for cognitive impairment. Like I said, all of our patients are at least getting a mini-cog, and if they score less than a 3 or we have other serious concerns, we are doing a MOCA test, not a SLUMS, but SLUMS is a very reasonable test to do as well. But we happen to do a MOCA test. MOCA, as you know, covers 7 areas of cognition. You don't, if you're working in most healthcare places, you don't necessarily have to pay money to MOCA, but MOCA says you should at least put the person through a 1-hour training course. And again, on camera, I just like saying this, I've never taken the course. 25 years I've been doing MOCA, I've never taken the course. But our department has decided that if our medical assistant is doing the MOCA test, they are going to take the 1-hour training course. So anyways, so those are all the additional requirements. So there's a lot to this visit, right? It isn't just as simple as what you may think it would be. And guess what? Clinicians are really bad at doing this visit because they show up, the patient starts talking about knee pain, they start dealing with the knee pain, they never get to all these things. Part of the work that we do when we go into practice is to help them. We have an auditing tool. We sit down with their health risk assessment and their note template, and we audit it and sort of see how close to these requirements do they come. And it's interesting because some practices hit 1 of these check boxes. Some of them hit like 98%, and they're all mad because they didn't ask about phone use. I'm like, you came pretty close, I think that's good. So anyways, all right, so why do these annual wellness visits?
How long are these visits?
Great question. So, you know,
An hour?
who knows, right? So some clinicians, and again, my apologies, I work in New Hampshire, so I'm gonna know a little bit more about New Hampshire. The Concord group practices are getting 20 minutes for this visit. Some of the clinicians that I work with that are on 30 and 60-minute appointments get 30 minutes for this visit. I have been stubborn and have not moved to 30-minute appointments yet, so I'm on 20/40s. I get 40 minutes for this appointment. Our geriatricians get 60. When we implement these visits as a nurse-run visit and non-FQHCs, we have the nurse do this in a 60-minute visit. Now again, hoping that health risk assessment is not part of that, right? Because if not, that's 20 minutes you're cutting into that. So when you talk about these poor docs in Concord who are getting 20 minutes to do this visit and that health risk assessment's not done, come on, these guys, that's why they hate this visit, right? Right now, so in the 10 years I've been working at this grant, we've been very successful in implementing this in like 58 different practices. I have a slide coming up that will tell the exact number. I think it's 58. I have been successful in those 58. I have not been successful in my own clinic. The clinic that I work in, I have not been successful implementing the nurse-run annual wellness visit. Recently, our geriatric department broke out of general internal medicine and created sort of their own department. They're in the same hallway as us, but they have their own section chief. They now are doing a nurse-run visit. The nurse comes in, does the visit in 30 minutes. The doc comes in after them and manages the CHF and the knee pain and whatever else. Both visits are billed. So 30 and 30 for that visit. So how long does it take? Nurse visit, we're kind. We give the nurse 60 minutes to do that. And we also tell the practice the nurse should only do a maximum of 77 of these in a day. So even though it's an 8-hour day, they should have time to do administrative stuff, shuffle paper and whatnot.
I thought, and maybe I heard this incorrectly or if I'm understanding it incorrectly, that you couldn't bill like more than one thing on an annual. So
Yeah.
the nurse going in and then the doctor.
So in non-FQHCs, you can split bill the heck out of this
Oh, okay.
visit. And again, like I said, if we have time at the end, I do have some slides that will break that down. All things being equal, in a non-FQHC, you could do the annual wellness visit, you could split bill in advanced care planning, you could split bill in an evaluation and management code for knee pain, and you could split bill in a knee injection, and you could add that G2211 code on there. So you could almost put 5 visits in that.
Okay.
So in a non-FQHC, whether the nurse is doing the visit and billing that incident too, and then the doc is coming in and managing knee pain or whatever, and billing that as well, they use a modifier on there to add that to the annual wellness visit. So yes, non-FQHCs, totally different story. So we mentioned it's free to the patient, no cost sharing at all. It has been shown in literature to improve the uptake of preventative services. By the way, if you ever go to Medicare's website and you look at all the preventative services they offer, there's like 50 different preventative services that they offer. It isn't just the standard ones that we know about. And of course, one of the main reasons why we're here today, and probably two of the biggest components of this, is really assessing cognition and mobility, right? We're going to talk about the 4 M's a little bit later of the IHI's, the Institute of Healthcare Improvement's Age-Friendly Health System, and the 4 M's, we'll talk about that. And Medicare annual wellness visits have actually been shown to reduce hospitalizations and additional Medicare costs going out up to at least 18 months after the annual wellness visit. So then comes the dementia gap, right? So we know all sorts of stuff about dementia, and we know that primary care really does a poor job of doing this overall, right? By the time I'm usually getting involved in diagnosing dementia, the patient is already pretty well established in that diagnosis, unfortunately. Part of the reason why is I don't want to rock the boat, right? And I mentioned before, people that were here, my dad's 91, and we're going through these conversations with him every single day. And as his son, or me as your provider, it's so hard for me to say, it's time for me to take the driver's license away. We just took my father's, we didn't. We had the Erie County Medical Center take his driver's license away. He had to go through this driving test. So it's so hard. I actually recently, I haven't taken new patients in years and years and years. And just recently I got one patient added into my panel, and it was from the geriatric team specifically. I'm like, you're going the wrong direction here. You have a geriatrician, now you're coming to me. Why is that? They pulled his driver's license. He got pissed at them. He fired them. Now he has me. I'm not giving his driver's license back, but you know, so it's really awkward. So having some of these discussions and not wanting to rock the boat really prevents primary care from getting involved in some of these. And time constraints, I think I already told you that before. Some of us are in 20-minute appointments. Can you imagine trying to have these conversations in 20 minutes? And then patients want to know why we're running late for their visits all the time? Like, it's crazy. And then, if I truly do discover that I think you have an issue, trying to get you to a specialty department, some research has shown 12 to 50 months before they can get you into a specialist. One thing, another little grant I worked on this summer was with our psychiatry department. They created this position in psychiatry called the Brain Health Navigator. Awesome, awesome, awesome. So now as a primary care clinician, somebody comes into me and says, hey, I'm worried about my memory. I do a referral to the Brain Health Navigator. They sit down with the patient. It's a 2-hour visit, 2-hour visit. They do the mini Kagamoka and all sorts of stuff. And they talk to the patient about, do we get biomarkers? Do we screen your head? Do we need, whatever. And they either initiate the workup and write the plan and send the patient back to me, or they just send me the plan and say, we're a little overwhelmed, can you scan this patient's head? But they give the whole plan and their assessment of what the patient is. So it takes me out of the loop.
What's the credential for the navigator?
So right now, the person that's doing that is a psychiatrist. Right? So the other challenge with when you have a patient with cognitive impairment is, do I send that to geri psych? Do I send that to neurology? Do I send that to the geriatricians, right? So the Brain Health Navigator is sort of like the quarterback. We send the patient there, they come up with a plan, and they're like, well, this type of dementia, I don't think the medication's gonna work, but they really need some behavior health modification, right? So then the plan may be sending that patient to psychiatry versus to neurology.
The brain health navigator that you're talking about here, is that like the Davos Alzheimer's recommendation for brain health? Because I just wanted to differentiate that navigator from the guide dementia navigator, which there's no requirement for a licensure.
Yeah, no, different.
Yeah.
This is just, like I said, psychiatry got a little bit of grant money
Yep.
to assess this position. And I think the only way I got roped into this is they wanted to see how I could get this carried into general internal medicine to see if we can feed them. And the first 6 months, I think we only fed them like 5 or 6 patients. It was really rough. Now I'm overwhelming them. So I think they're happy about that, and I think they're looking for more hard money now instead of grant money to continue this good work, because it is huge. Because I get clinicians all the time that are like, where do I send this patient? Like, I'm worried they have this, but do I get an MRI of their head? Do I order and I don't know how to interpret biomarkers. So if any of you guys are specifically in that field, congratulations. I have no idea what to do with that. I'm not even sure, like, what type of scan do I get on their head? Do I get an MRI, a CAT scan, with, without? Do I throw in the carotid arteries? I don't know. It's, and I think sometimes it's such a moving target, especially now with the biomarkers and some newer meds coming out. Thank goodness for the behavior health, or the brain health navigator. It's been huge for us. So, but again, even that, when I was trying to refer people to Jerry Psych, it took a long time to get them into that department. So we already talked a lot about this. So CMS does require cognitive assessment as part of the annual wellness visit. Of course, it will not go out on a limb and tell you specifically what you have to do, but we do know that the mini-cog is validated, and we do know about the slums and the MOCA, which are some of the other validated screeners. By the way, what is this thing called? And what else is it called?
Dromedary.
Yes, thank you. Medicare actually lists that as I'm like, I wouldn't have known that, right? And I'm always gonna fail this part down here, the date. I never know what date it is, right? So if I take this thing, I think 3 points right off the bat, just coming off of there, right? And of course, I'm in Lebanon, right on the edge of West Lebanon and Hanover. So if a patient gives me any one of those 3 things, I'm like, you're close enough, right? By the way, nurses can do this visit. This visit does not have to be physician-driven. Again, when we're talking about time and we're talking about money, since I always have to be the bad guy, why am I paying a doc $100 an hour to do this annual wellness visit? Because in non-FQHCs, this annual wellness visit is only reimbursed about $124. So there's no way I'm making any money on doing this visit, right? That's just the dollars and cents. As I mentioned before, and this is a slide deck, right? I've done tons of research on this, and I've crammed, all this work down into like a 40-minute presentation. Physicians really stink at doing this visit because they get sidetracked. They don't like the visit. They don't think there's value in the visit. So it doesn't get done properly. When we first worked with particular practices in New Hampshire, and I won't mention their names, they're like, we're doing this, we're knocking it out of the park. And we audited their notes and went to the billing department. So the clinic thought they were doing about 400 of these a month. Like, awesome. We went in there, we were like, wow, you guys are the gods. You probably should be telling us how to do this visit. And we went to the billers and coders, they're like, no. Like, they maybe get 20 of these out a month that are billed properly. So the clinician thought they were doing it right and not. I actually, in my own practice, audited an annual wellness visit that was a pre-op physical but billed as an annual wellness visit. So there wasn't even one of those boxes that were checked off. So nurses can do this. And by the way, I don't think this is extra work for nurses. I think this is the right work for nurses. Do we have nurses in the room? Right. Triage nurse on the phone? Off the
Clinical
phone?
director.
Okay, well, really fancy.
Yeah.
Okay. Anybody on the phones?
Care managers.
Care managers? Okay, well, that's fine. Triage nurses, I guess. You're a triage nurse? How many hours a day do you spend triaging on the phone?
All day.
The whole
I
day?
mean, let's say 6 hours.
6 hours, okay? Do you want to eventually see a patient again, or is this what you really want to do? And I'm sorry, you raised your hand, I'm gonna put you on the
Go for
spot,
it.
so.
Well, I actually do annual wellness visits as a different job. So
Yay, she actually does
I
annual wellness visits.
market them as a time to talk about all of the things that they don't get to talk about.
Yep. So in one of the practices down south of New Hampshire, they had 5 triage nurses who said they could never get off the phone. So we went in there and we said, 1 day a week, one of those nurses is coming off the phone and doing annual wellness visits. And we rotated through. Guess what? Their call volume didn't change, because what we found out is the nurse was spending too long on the phone with the patient. Now that they only had 4 to do the same amount of work, they were a little bit more efficient. Not only that, now one of the nurses got to do annual wellness visits 1 day a week, so they got a little breather from having to answer phone calls all day long. No offense, I could not do phone triage all day long. It would drive me crazy. Some nurses don't ever want to touch a patient again. They're happy on the phone. God bless them too. So when we did this rotation period with these nurses, they absolutely loved it. So nurses, I think this is the right work for them. Working at the top of your license, right? This is another thing that we really try to promote, so.
Can I ask a quick question?
Yeah,
Are the cognitive screen, I'm gonna miss this, only prompted if the patient says yes to that?
so that's a great question, and it depends on the workflow in your clinic. So there's no standard rule. Medicare, again, is very vague, says you should assess cognition.
They don't say.
Then what?
Yeah.
Then
On
what?
every patient.
Yeah, like every patient, whatever.
Okay.
So could my one question be that assessment? And you say, yeah, I'm worried about my memory, check.
Because a lot of
Okay,
people have
sorry to hear
insight,
that.
you know, like, if you're asking a patient who does have memory issues, they might have insight that they have a memory issue, you know? So
Yep.
that's the only reason a cognitive assessment's getting prompted, but that's.
Yes, and, right, so if they don't check that off and
Yeah.
you're missing the
Yeah.
opportunity to do a mini cog. So, interesting enough, in my department, when we first built this health risk assessment, the workflow was, the rooming staff was only to do a mini cog for a patient who identified, yes, they had a trigger. But guess what? Our rooming staff was so bad at actually reviewing the health risk assessment that they, on their own, just decided it was easier for them just to do a mini cog on everybody. So the mini cog list, it takes a minute, like it took them longer to pull up the computer and actually look at the health risk assessment. So we changed the workflow that every patient gets a mini cog regardless of that question. And then if they don't do well on the mini cog, we'll do a MOCA.
Thanks.
So in FQHCs, do we have people that are FQHCs here? So a couple, okay. So in FQHCs, some of these rules look a little bit different than non-FQHCs, right? So FQHC gets reimbursed under this thing called a prospective payment system. You get this amount of money to do this visit, okay? But one of the requirements is that the physician or the primary care provider has to do a face-to-face visit with that patient on that day. Now, that being said, nurses or medical assistants can do a lot of these components, but the physician or non-physician practitioner needs to come in at the end. And there's some listed responsibilities. So now, starting in 2025 to 2029, our grant, we're required to only work with FQHCs. So a lot of FQHCs are really confused about the nurse-run annual wellness visit. So we worked very closely with the National Association of Community Health Centers and basically got definitive language. Tell us, so first of all, that group that I just mentioned did a webinar on the nurse-run annual wellness visit, and all these FQHCs joined and did the webinar. And they talked in circles, which is classical for Medicare language. And looking at the chat, nurses were still saying, can the nurse do this visit? Like, they didn't clearly come out and say yes or no. And then finally people were like, yes or no, can the nurse do this visit, right? So what we come to find out, the answer is, of course they can participate, but they cannot bill independently. So we came up with this great model, right? So you go to the dentist, the hygienist spends whatever time, 40 minutes cleaning your teeth, and then the dentist makes a guest appearance and says, oh, move your tongue that way, move your tongue that way. Oh, no, glands are great. See you next year, right? So that's the same thing for the Medicare annual wellness visit in an FQHC. The nurse or the auxiliary personnel, as Medicare or an FQHC likes to put the language, does the majority of the visit, and the authorized billing provider makes a guest appearance at the end. Now, of course, they don't even say what that billing provider has to say. They just basically say they have to sort of make a guest appearance. So it's a little vague as always, because that's how we roll in Medicare. In non-FQHCs, like I said, the nurse can actually do this visit 100% independently. The nurse can do the entire visit and bill incident to a provider that's actually in the clinic suite, and they do not have to actually come into the visit directly, but they have to be there. So if the primary care provider of that patient is in Hawaii, that you cannot use the primary care provider's billing code. You have to use somebody in the clinic. So if there's bean counters in the room that are like, what's going on with this then? Because now the doc that happens to be in the clinic is getting RVUs, relative value units. They're getting bonus points for a patient that's not even theirs. Okay, well, whatever, eventually you're not gonna be there and someone's gonna do an annual wellness visit on your patient, or don't take any more vacation, just stay in clinic all the time, and then you can get all these RVUs that your nurses are doing. So, but the provider does not have to come into the room at all. So, why an annual wellness visit? So we know, first of all, nurses are really good at doing this. The nurse that we have in our geriatric department that is doing this, first of all, is following our template, which is great. She's loving it. She's kicking it. She's doing such an amazing job. We've audited so many of her notes. She's hitting every single one of those check boxes. And it's already been shown she has done health maintenance that the doc hasn't done in years, including like mammos and colos and even routine lab stuff. So it's really good. Job satisfaction, again, for the triage nurses that are in the room, I'm not sure that's a job for me. I don't think I could survive doing that. I had a hard enough time during COVID doing that. I'm a hands-on guy. I want to see a patient. Also, by the way, if you're in this rotational situation with the nurses, you've met Mrs. Jones, and now she calls on the phone. How cool would it be say, hey, Mrs. Jones, this is Samantha. Remember, I did your visit last week. Oh, hi, right? So you build that rapport as well. Working at the top of your license, oh my goodness, we need to do a much better job of that in healthcare across the board, even for physicians. Why do we have physicians filling out these silly things that other people could be doing? Why are nurses doing things that a medical assistant can be doing? And why do we have medical assistants doing things that the administrative assistant should be doing? So we all need to be working at the top of our license. Because I'm always the bad guy, we can make more money too, by the way, right? So if we're only paying a nurse to do the same visit that we're paying a physician, we can increase that. Of course, we created a calculator to identify potential return on investment by doing a nurse-run visit. One nurse, one doc. If you put all the nurse-run visits to the nurse, and then the doc could bang out a 99213 or 4 during that same amount of time, there's about a 300% increase in dollars and RVUs for doing a nurse-run visit. And guess what? The pushback we get from practices, we can't afford to pay a nurse to do these visits. Really? You're paying a doc more money, how can you not? Now we get the staffing issue, right? We just can't find nurses, but don't give me that as an excuse, just say it's staffing, you're better off with that. But, so great thing. And again, here's the patient scenario. So Mrs. Lewis, 72 years old, comes in for her annual wellness visit. She gets a mini cog, and the mini cog shows some concern. She does a MOCA. The concern is even higher in the MOCA. So she sets the patient up with the primary care provider to have a discussion and find out, do we need to do something, right? So the other thing is you have to find out, is this memory concern acute or chronic, right? Does Mrs. Lewis have a urinary tract infection and she's just not firing on all cylinders today? Or is this a chronic condition? By the way, that may or may not be my dad's mocha. And as we know, earlier diagnosis is better planning and reduced family stress, right? I told you, some of you guys that were here earlier, last night I got a call from my patient, who is the daughter of the dad, who is not my patient, who's been lost multiple times in the past couple of days, found 3 hours away from his home, threatening to kill himself, significant memory issues. So getting these people into care sooner is clearly a much better option. So that being said, I'll tell you a little bit about what we're doing. So again, we're part of this grant called the Geriatric Workforce Enhancement Program grant. We're one of 42 across the country. We've had this grant in its variation since 2015. Prior to that, we actually held that, and it was called a GEC, and people always ask me, and that's an acronym, I can't remember what it was. GECs used to be all about butt in the seats training. You stand in front of somebody, you give them a big speech, and you walk away. That does not correlate to in-practice care. So now with these grants that we work on, we have to work with practices. When we implement the annual wellness visit in a practice, we're with that practice for a full year to implement that. And they don't pay us, we pay them, if you're an FQHC currently. So under this grant, we actually developed two main categories. So we have this GET-PC, which stands for Geriatric Interprofessional Team Transformation Primary Care. We created a GET-SNF1 for skilled nursing facilities as well. I do not sit on that, so please don't ask me a question about that. And so we work on these 4 Medicare reimbursable codes, so the annual wellness visit, chronic care management, transitional care management, and advanced care planning. We keep getting asked to do the annual wellness visit over and over and over again. We just finished a cohort of 5 practices for the annual wellness visit. We're ready to go on to TCM, transitional care management, and we have just more practices that want the annual wellness visit again, so we are doing the annual wellness visit again. This is sort of our reach. Since 2015, we've been in 8 states, 56 different practices, and 21 FQHCs. Multiple publications, multiple national presentations. Dr. Ellen Flaherty, who is the Vice President of the Dartmouth Centers for Health and Aging and the Geriatric Center of Excellence, is actually the co-PI of the GWEP-CC. This is a coordinating center of all the 42 GWEPs. So our GWEP is actually one of these ones that helps coordinate the work that all the other GWEPs are doing. We are headed to Boston for the Gerontological Society's National Conference next week in Boston. All these 42 GWEPs are getting together on Tuesday, and we're sort of sharing the information that we've done. So that is all coordinated by us. You notice Georgia's in yellow. So we did not necessarily do this whole year-long thing with Georgia, but Georgia got this huge grant, state budgeted line item to initiate cognitive assessment in primary care. They used our model across the entire state to implement this screening. So we're very honored to be part of them. We've still yet to actually cash their check. That was like from 5 years ago. We're just happy to do this, and you're doing the right work. Of course, you have the thing, the annual wellness visit is a gateway to the Institute of Healthcare Improvements 4 M's. Familiar with the 4 M's, people, mostly? All right, so the 4 M's was an initiation of the Johnny A. Harford Foundation. Who knows what the Johnny A. Harford Foundation is? Great. What grocery store do they own? Trivia question. So the Johnny A. Harford Foundation were actually the owners of the A&P grocery stores. So if you're old enough and you happen to remember what A&P grocery stores were, Johnny A. Harford Foundation, those were the people that owned those grocery stores. They clearly made a lot of money, and now they basically support primary care in providing better care to older adults. So they help subsidize these massive grants that we're working for. But the Johnny A. Harford Foundation with the Institute of Healthcare Improvement created this thing called an age-friendly health system, and they promote these 4 M's. What matters to the patient? This is mostly around advanced care planning, but we do ask a question, what matters to you? And maybe your answer is I just want to see my grandchild graduate from high school. Great, whatever we have to do, we'll get you there, right? Because a lot of times in primary care, we come to you and say, well, we want to address your cholesterol, and then the 88-year-old's like, I don't care about the cholesterol, I just want to see little Johnny walk across the stage, right? So making sure that what matters is important. Medication, we look a lot at the Beers criteria, which is this criteria that looks at high-risk medications older adults should not be on, and we de-prescribe some of these medications over time. Mentation, why we're all here, right? So really making sure that we are addressing mentation. And then mobility, the other one that's near and dear to my heart as well, is really making sure a patient can have mobility to maybe go back to improve on what matters to them. So when we work with practices now, we actually get them at least a level 1 certification with an age-friendly health system. That's a certificate that you plaster on the wall and you get your name in the newspaper for. So all you have to do to get level 1 is to identify intentions of incorporating the age-friendly health system. To get a level 2, which my clinic is, you have to show data. Guess what? We help practices do that too, because this is the gateway to the annual wellness visit. So if you're truly doing the annual wellness visit and you've incorporated that, there's our data. So a lot of practices were able to get level 2. By the way, why is this important? Look at this. This is rough numbers. Only 16% of primary care practices are doing any form of cognitive assessment. That is not great. Even the other 4 M's aren't great, but cognition is the lowest, which is really sad. This is what our training program looks like. So first of all, we go out to a practice, we do a 1-hour practice assessment. We sort of find out where you're at, what you're doing, what electronic medical record are you on, and I do an audit of your note template and your health risk assessment, and then sort of tell you roughly where you're at. Then we do 1-hour learning modules that we want sort of the interdisciplinary team. So we want the billers and coders, we want IT people, we want nurses, secretaries, rooming staff, we want everybody part of this group. Then we do a 3-hour in-person. We go to your practice. We do a 3-hour review of everything. We even look at your EMR and see if there's other things we can do to help you there. Then we get all the practices we're working together for this kickoff. This is in person, usually about 4.5 hours. We have great stuff. We do a Mr. Potato Head, and we do some QI work and that kind of stuff. And then we continue with Learning Collaborative. Thank you.
I'll be at GSA next week.
Okay.
So I'll be at the Alzheimer's Association booth.
All right, I'll look you up. My business card's here if anybody's leaving and wants to chat more. We can
Thank
do
you,
that.
I'm sorry I had to leave.
No worries. So the other thing is we do this learning collaborative at least 5 to 6 months, an hour a month. We get together and sort of find out what areas people need. And then we continue with office hours after that. So we have dedicated office hours. You show up and we help you. So this is the cohort that we just finished up. I know we're running really close on time and I want to be mindful. Basically, this is huge. Practices were all happy we showed up and they just really felt that we could really help them do this annual wellness visit more efficiently. Some take home, so basically the annual wellness visit is underutilized. We can have nurse-run workflows and we can do cognitive assessment as part of routine screening, just like blood pressure and other vital signs. We know early detection is really important to good care. And screening should just feel natural to us. Let's see. Call to action, basically, let's try to work on this together. If you guys are interested, here is some information about our GWEP. Annalise is really our coordinator for that. I'm just one of the worker bees. There's our QR code. I do have business cards up here as well. Here is my contact and my QR code. That just takes you to our website directly. I'm happy to stick around. I'm going to stay for the next presentation anyhow. I did have some very specific additional slides, which I think if you guys have given the slides, you'll see more specific billing information around FQHCs, very specific stuff. Well, one thing, and I'll just take a half a second to do this, is This is one of the interesting things, is that the Medicare annual wellness visit in FQHCs actually gets billed out about $271. That is really good, by the way. So if we keep that number in our mind, 271, that when we compare that to an established care visit in FQHCs, that visit is about $202. So here's the real bad part about annual wellness visits in FQHCs. Depending on how much work you do, if you start off doing an annual wellness visit and then the patient brings up knee pain and CHF and you start managing a lot of that stuff, your coder may actually drop that visit from the annual wellness visit to that evaluation and management. So now you've done 2 visits and you're getting less money for the visit. And the reason is because this is free to the patient, no copay, no deductible. But when you start talking about knee pain, we have to have copay and deductible. And that's why your biller or coder typically has to do that. So you could be doing more work and getting less money. So we need to figure out how to separate those. No free breaks, right? So we want people to pay for their breaks. In non-FQHCs, an annual wellness visit is getting billed out about $126.
But you can throw something else on top of that.
Will you stop taking my presentation away from me? But, as we mentioned, there's no free breaks. So I can split bill the heck out of this, right? As I mentioned before.
But FQHCs
I
aren't
could
allowed
do
to.
an evaluation and management, and I can throw in advanced care planning, and I can do this G2211 code, and that can bring me to $251 for doing all that. Still less than what an FQHC is getting for the annual wellness visit. All right, I'm gonna end there. Business cards are up here if anybody needs it, and I'm gonna hang around, so if there's questions at the end, I'm happy to address those as well.